My name is Jolan Walter. I am the Robert A. Good Chair of the Division of Pediatric Allergy and Immunology at Johns Hopkins All Children's and University of South Florida. And I'm also a consultant in immunology at Mass General Hospital at Harvard Medical School. I'm excited to be here and share with you my thoughts on the diagnosis and management of autoimmune cytopenias in primary immunodeficiency. So today we will learn about the definition of autoimmune cytopenias, in particular ITP, immune thrombocytopenia, AAHA or autoimmune hemolytic anemia, and autoimmune neutropenia. I'm going to touch on the diagnosis and treatment options for these disorders in the primary immunodeficiency populations. And we will go through two examples of treatment challenges. And the first example will be a child with partial DiGeorge syndrome and cytopenias. And the second example will be a patient with CVID, common variable immunodeficiency, and an underlying CTLA-4 deficiency. When I think of autoimmune cytopenias, in my mind, we have to segregate two different types of cytopenias. One is that is happening acutely. We call it acute autoimmune cytopenia, and it can be a hematologic emergency. The patients often need admissions, administration of high-dose IVIG and steroids, and occasionally transfusions. And this is in contrast of chronic cytopenias, when you have a smoldering disease, the platelet count or hemoglobin hematocrit can be sometimes just below normal or decreasing slowly. And in this case, many of the patients are monitored only empirically and treated as needed. However, before we even move to these different entities, I do have to emphasize the importance of determining that the cytopenia is of autoimmune origin. And that could be confirmed either by the detection of antibodies to specific cells, such as the platelets, the red blood cells, or the neutrophils. But it's not uncommon that the clinicians make this decision that is autoimmune based on clinical impression. As you have seen in my introduction, in case of the acute hematological emergency, it's not uncommon that patients would get high-dose IVIG that can completely blur the picture of the presence of autoantibodies. And if the patient responds to high-dose IVIG, it can often convince the clinicians that truly the patient has an autoimmune process. Among the three separate entities of ITP, AN, and autoimmune hemolytic anemia, or AIHA, I want to emphasize a new term for you called Evans syndrome. In case of Evans syndrome, we have two or more lines of cytopenias, such as you can have a combination of ITP with hemolytic anemia or neutropenia with any of these entities. And what is important is that these cytopenias may not come at the same time. So we have followed patients who probably initially presented with ITP, but then developed an episode when autoimmune neutropenia was more predominant, and so on. So they can segregate with time. And what we also need to understand that autoimmune cytopenias in PID can affect patients of any ages. It's not uncommon to hear about young children having episodes of thrombocytopenias, but we also have sometimes clinical history of patients coming with the cytopenia at adulthood. So when you think about the mechanisms of cytopenias, and here I'm showing you an example of mechanism of hemolytic anemia, you can think of many different processes leading to the destruction of red blood cells. And what happens is that the red blood cell occasionally is covered by specific antibodies, and these antibodies would be making the red blood cells palatable to other cells, such as macrophages, who would come and try to destroy the red blood cells. And these cells could go then to the spleen and fully get demolished, and their products, like byproducts, are used for building other cells in the body. It is not uncommon, though, that by binding the red blood cells, the antibodies would bring in other components of the immune system, such as the complement, that's C3b right here. And through that complement binding, they would actually destruct the red blood cells with the innate system, the complement system. And many of these processes are going to finalize their stages in the liver. So as you can see, there are many, many different ways of destructing a red blood cells in the periphery through an autoimmune process, but the presence of antibodies are clearly an important component of this disease. So this is an example of ITP, immune thrombocytopenia, as one of the other common entities of cytopenias. And the patient would show obvious signs on their skin. You can see the tiny little bit of the red dots that are scattered around the lower extremity of this patient. We call them petechiae. And then when they become a bit more confluent and larger patches are seen, and then it is called purpura. And these are both very important clinical findings of a patient having an acute episode of immune thrombocytopenia. But what we learned about these cytopenias is that they are often quite hard to treat. Not every patient would respond to first-line therapy, and sometimes they have to go through several rounds of treatment with other agents before they actually have something working for them. What we also learned is that in immune-deficient patients, the onset of cytopenias may precede the infections phenotype. So as we are moving forward with neuro and neurogenetic disorders, such as CTLA-4 deficiency that I will present to you as the second part of my talk, you will notice that many of these patients will not have cytopenias as the second or third type of presentation of the disease, but as the first manifestation of the disease. And lastly, these cytopenias are not coming alone. Many of the patients who have cytopenias would have other disorders such as lung disease, enteropathy, even potentially vasculitis, vitiligo, alopecia. And on the right side, I want to emphasize again that although infections are a common theme in immunodeficiency, and we can treat them with antibiotics and immunoglobulin replacement therapy, we have a much harder time controlling and taking care of the non-infectious manifestations in our patients, such as autoimmunity, inflammation, and malignancy. And cytopenia is actually the most common non-infectious manifestation in these disorders. And this is a very important paper that we tend to bring up in our scientific meetings. The paper was written by a French group led by Alain Fischer in 2016, when he's shown very nicely that patients, children who develop hemolytic anemia in the immune deficient group have an 830 times higher risk of developing cytopenias than a general patient population of the same age. And even for immune thrombocytopenia, the relative risk is 60-fold higher. What he also has shown is that autoimmunity occurred at least up to 30% of the children, depending on the underlying immunodeficiency. And if the patient had a T-cell disorder, autoimmunity could occur half of the patient by 40 years of age. So what it really told us, this nice cohort study, a very eloquent study, is that we really have to pay attention to our patients' history of cytopenias, and those who have cytopenias should also be considered for evaluation of immunodeficiency. So when I think about immunodeficiency, we really think about the other side of the coin too, that not only primary immunodeficient patients have tendency for cytopenias, but what we believe is that cytopenia patients can have a tendency for immunodeficiency. And what we have seen is that as high as 40% of patients with the multilinear cytopenia that I called Evans syndrome in the prior slide, we think that those as high as 40% of these patients can have an underlying immunodeficiency. And we actually published recently a study of our own experience here in Florida at Johns Hopkins All Children's, and looking at a retrospective set of 3 years from 2013 to 16, we found 10% of our patients with cytopenia having signs of immunodeficiency, and half of them actually had a confirmed monogenic disease. And this is probably the tip of the iceberg. We have now prospective studies showing even more involvement of immunodeficiency in the cytopenia population. So what I want to take home from this slide, and hope you can also appreciate it, that the hematologists and the immunologists have to work very closely hand in hand in helping patients to be diagnosed with immunodeficiency disease, and those who already have a diagnosis to treat them properly. And that's going to take me to a short summary slide in the middle of my talk, how to find and treat primary immunodeficiency patients in autoimmune cytopenia cohort. If you think of these patients, you really have to consider their clinical history. Most of the time, as I mentioned, cytopenia is not coming alone. There are multiple other autoimmune manifestations that can occur in the patient's clinical history. And most of the time, the cytopenias progress with age, and they have a treatment refractory course. Those who have immunodeficiency underlying the cytopenias also tend to have family history. Although the penetrance could be variable, some of the family members can have milder disease, whereas others could be having more severe disease. And that could apply to both the infectious and non-infectious complications. What has been confusing when we were looking at patients with cytopenias in general is that the basic immune phenotyping can be actually falsely reassuring. And this is more commonly seen in the ARPS and IPEX populations. If you have a patient with antibody deficiency syndromes and T-cell defects such as CVID and CID, the basic immune phenotyping will be very telling. However, those patients who have an immunodeficiency related to the apoptosis pathway, such as ARPS or IPEX disease, it's not uncommon that these patients may have a normal basic immune evaluation, and you have to go after very specific immune cell types to confirm the disease. And this also applies to many of the types of the primary immune regulatory disorders, or PIRDs. So because the basic immune phenotyping can be falsely reassuring, it is of high importance that patients with concern for immunodeficiency and cytopenias are going through genetic screening. And also, we have to be doing a better job in understanding biomarkers that are needed for the diagnosis, but also for the treatment response. It's not enough to find a patient with an immunodeficiency and cytopenias. It's important to treat them properly and see if the treatment is working. Most of the time, these patients go on bridge therapy to control their immune dysregulation, but it's not uncommon that patients may have to move to hematopoietic stem cell transplant or bone marrow transplant in selected cases. And why should we care about these patients and with autoimmunity in PID? First of all, those who have an autoimmune complication seem to have a lower lifespan than those without autoimmune complications. And this is, again, the same study from France that have shown that patients who had only primary deficiency with infections and no autoimmunity, around 75% of them survived up to 80 years of age, whereas patients who had both autoimmune complications and the typical PID presentation of infections, their survival was as low as 60%. And this curve is still better than what we have seen in the prior studies from Dr. Charlotte Cunningham-Randall's, when the survival was even lower than this. So I think with the clinical care and diagnosis, we are improving the lives of our patients, but there is still a significant difference between the outcome of these two groups. So again, why should we care about autoimmune cytopenia in PID? Because we can actually provide targeted therapy. And this is a short summary of the targeted therapy that we try to give to our patients with cytopenias. In normal circumstances, when you have a patient who have a low platelet count, it's not uncommon that the hematologist would observe the patient. And unless it goes below 10,000 or 5,000, there is no clear action to treat that condition. However, if the platelet count is decreasing rapidly, first-line therapy would include steroid and high-dose IVIG. And if it doesn't improve long-term, the platelet count, then it's not uncommon that our patient have to go to second-line therapy. Interestingly, based on the ASH guidelines, the number one second-line therapy is actually to increase bone marrow output of platelets. with certain thrombopoietin agonists. The problem with that approach is that we keep on pushing platelets out to the periphery and letting them to be destroyed by immune mechanisms. So I personally favor in outpatient populations a more targeted approach when we try to go after either the autoreactive B cells or the T cells that are going to promote autoreactive B cells. And that could lead us to using elimination of B cells with rituximab, or using T cell suppression with CellCept or sirolimus. It's also not uncommon that we would go very specifically to the regulation of Tregs or regulatory T cells by using CTLA-4 Ig, which could be very successfully used in some of the CVID populations. Similarly, in case of hemolytic anemia, patients are often monitored unless they drop their hemoglobin level very rapidly. And in those cases, steroid and high-dose IVIG are not uncommon to be used. But long-term hemolytic anemia patients do need more targeted second-line therapies, which may include rituximab or T-cell suppression. And here I just highlight a couple of the disorders that I'm going to discuss with you during this talk, where you really would like to come to the second-line therapy specifically to T-cell suppression and not to go through the entire 1, 2, 3 checkpoints before you come to this decision-making. So for example, ARPS, patients with autoimmune lymphoproliferative syndrome, first-line therapy is now using sirolimus or MMF because they seem to be much more effective than any of the other interventions. We have similar experience with partial DiGeorge patients using a combination of immunoglobulins and T-cell modulation. And as I mentioned to you, CTLA-4 deficient patients with common immunodeficiency do very well with CTLA-4 Ig, which is clearly a targeted therapy for their case. So I'm going to go through 2 very quick reports of 2 children, actually an adult and a child that I'm following here in Florida, and through the example to show you some of the challenges that we have to face in treating cytopenias and immunodeficiency. This first child I'm going to introduce you is a young girl who had partial DiGeorge syndrome. The image here on the left is actually not our patient. I found it on the internet. And I thought that this was a nice example of a child with partial DiGeorge syndrome. And you can see on the right that patients with partial DiGeorge syndrome have very typical features: low set ears, they can have congenital heart defects, they can develop additional features, both organic and non-organic disease, including asthma, atopic dermatitis, and even developmental disorders, speech delays can occur. This is a complex disease, and I was surprised to see when I had my first patient with cytopenia how difficult it is to take care of cytopenias in this population. So this case in particular was an 8-year-old patient who was referred to us urgently from hematology. The patient had a GI bleeding with a procedure, and the hematologists were called because the bleeding would not stop. And what we heard about at that time through our colleagues in hematology is that the patient was from Ukraine and had a cardiac surgery at birth, but it was unclear whether there was a genetic disorder underlying this cardiac defect. And otherwise, the mom reported that the patient was healthy with no history of severe infections, and the parents were mainly concerned for celiac disease, and this is why they had an intervention with gastroenterology. At the time of the physical exam, the patient actually appeared quite normal with very mild dysmorphism. And the consult was primarily for the severe anemia and low platelet count and neutrophil count that was found at the time of the bleeding. So the hematologists were extremely concerned about this patient. And the patient actually had an urgent bone marrow biopsy to rule out malignancy. And they indeed ruled out malignancy at that time. But interestingly, the karyotyping, the actual examination of the chromosome of the patient, revealed a 22q11 deletion, which is a pathognomic feature of partial DiGeorge syndrome or DiGeorge syndrome. So it is very surprising to the immunologist that a patient came to our attention not because of their dysmorphic features or because of their infections, but actually because of an intestinal bleeding and the low platelet count and hemolytic anemia that we discussed in the past as a sign of autoimmune cytopenia. So we did immune evaluation, and it did reveal that the patient actually had T-cell lymphopenia. The T-cells were low in count, and also mild hypogammaglobulinemia, but not to the point that it would make the patient prone for very high frequency of infection. So she was sort of smoldering a very mild immune disease. However, against this milder immune disorder, she had a significant autoimmune cytopenias, and we had to decide with the hematologist how to treat this disease. So this is an actual poster that we presented at the CIS and shows you the saga of the treatment plan for this patient. As you can see, the patient had a variation of different combination of the cytopenias. In the abbreviation, you can see hemolytic anemia, ITP, and neutropenia. And these episodes were coming to the point that the patient had to come to the emergency room several times because the neutrophil count was just so low. And that initiated the use of GCSF injections that can increase neutrophil count. So a few years, maybe a half a year into her evaluation and management, the family finally agreed to have immunoglobulin replacement therapy started. And to be on the safe side and to have the most effect of IVIG, we actually decided to start at high dose to control the cytopenias and at the same time prevent infections. And then from the IVIG version, we actually moved to the subcutaneous version. But even on this treatment, the patient had fair response and still had repeated episode of Evans syndrome. So once we decided that the immunoglobulin was not sufficient alone, although it showed some benefit, as you can see, there were some increase in the platelet count. We decided to move to the T-cell directed therapy with sirolimus, which is a T-cell modifier agent. And with the combination of the subcutaneous immunoglobulin and high dose and the sirolimus, we actually could benefit the patient and increase the platelet count and control the autoimmune neutropenia. So I would say it took us a little while to figure out how to control her disease, and we had to think about the underlying cause before we came to the conclusion of a combination therapy for this patient. Now I'm going to move on to my second case, which will be a little bit different by age and underlying disease. This is a case of a teacher who had a CVID phenotype. In fact, she was found to have CTLA-4 deficiency at the age of 50. And again, this is an example of a teacher on this figure. It is not our patient, but I just wanted to give you an example of a teacher who is always very busy. She is in between classes. She's trying to help children to learn, but at the same time, she has her own disease to take care of. And the way my patient described it is that she had a hard time in between classes to make it to the bathroom because she had really bad enteropathy. And she also had severe asthma exacerbations, and that required a lot of steroid treatment. And that had an effect on her body. And at the same time, she was still prone for infections, and quite a bit she had history of low platelet count. So that brought her to me, and with some important findings in her family. In fact, our index case, which is in the middle of this graph in red circle, was related to a twin of 50 years of age actually at that time, who were followed in Boston. And these siblings were found to have severe ITP, immune thrombocytopenia, for a very long time. And one of them even developed an enlarged spleen that had to be removed. So with that history, and then with the family history of ITP and several members of the family, as you can see, the clinician, the hematologist in Boston, actually elected to sequence the genetic material of these initial twin siblings, and he found that these patients had a CTLA-4 deficiency. The CTLA-4 variant, although was a variant of uncertain significance, which means that it has not been published before in context of this disease. So the family started to test other members of the family to see who has this variant, and this is why our patient ended up with the diagnosis. And we tested further her children and found another family member in her family, a little boy who also had the CTLA-4 variant with asthma. So when we did this call and we understood that there is an interesting variant in the family, we really had to make sense of that and in connection to the cytopenias and other autoimmune complications that this patient was suffering from. And we did some laboratory evaluations, we did immune phenotyping, and indeed we could create a connection. So not only we would treat the patient with immunoglobulin replacement therapy and antiviral, antibiotic treatment, but we could also justify for her the use of CTLA-4 Ig as a very targeted therapy. And once we placed her on CTLA-4 Ig, she actually improved dramatically, and she reported that her life as a teacher has improved because she didn't have to rush to the bathroom in between classes, and she could breathe better. Her asthma was getting under control, and her skin color was improving, and she didn't have cytopenias anymore. So we basically could make a major difference in her life by finding the genetic disease and using targeted therapy for her cytopenias. And I do want to mention that, again, some of the patients who receive therapy can do so much and improvement on these therapies, and eventually they may have to receive bone marrow transplantation. And it's not uncommon that patients who have cytopenias actually evolve into malignancies, and that would be another indication for bone marrow transplantation. So my take-home message for this talk is that autoimmune cytopenia is quite common in all PIDs, and this is a review that I wrote 2 years ago. And you can see that no matter where you look, what type of infections, complications with PID or autoimmune type of PID you look at, they all have cytopenias. But in particular, I do want to emphasize the importance of knowing about the group called PIRD, or primary immunoregulatory disorders, because these patients tend to have an accumulation of autoimmune disorders and cytopenias. So you can see the plus sign across the line here that these patients have not only cytopenias, but autoimmune thyroid disease, endocrinopathies, enteropathy, arthritis, vasculitis, and you name it. So what we have to keep in mind that if you have a history of recurrent cytopenias, but also other autoimmune disorders, it is possible that you may fall into the PIRD category or some of these other disorders on the left, which can have a combination of cytopenias with other autoimmune disorders. And again, PID patients have multiple autoimmune diseases, such as in some of the cases, up to 77% of the patients will have multiple autoimmune disease. The PIRD group I mentioned too is highly enriched in autoimmunity, so you have to consider that as a diagnosis for yourself if you have multiple autoimmune cytopenias. And now we have large cohort studies in specific genetic defects, and we could actually establish that cytopenias can really precede the onset of infections in PID, such as in case of CTLA-4 deficiency, 33% of the patients with cytopenias will present before they actually have infections. And I can't emphasize it enough how important it is to work together as a team with all of the other specialists. And we do honor our, and we really are grateful for our colleagues in all the specialties who share their patients with us from different hospitals in our region. Without this collaboration, it would be very hard to take care of our cytopenia patients who also have other autoimmune complications. And without further discussion, I would like to thank your attention. Here's our contact information, and please feel free to reach out to us anytime with questions. Thank you.
Hi, everyone. Thank you so much, Dr. Walter. My name is Julie Magnuson, and I'm with the Immunodeficiency Foundation. We're going to go ahead and get started with the Q&A portion of today's session. Before we begin the Q&A, please remember that each individual's treatment and condition is unique. The information presented during this session is not medical advice, nor is it intended to be a substitute for medical advice, diagnosis, or treatment. Always seek the advice of a physician or other qualified health provider with questions concerning a medical condition. At this time, please join me in thanking Dr. Jolan Walter from the University of South Florida at Johns Hopkins All Children's Hospital for that wonderful presentation and saying welcome to the Q&A portion of this session. We've received some great questions so far, so let's go ahead and get started here. The first question we have is, can you test antibodies of autoimmune while on IG replacement?
This is an excellent starting question, and thank you so much for bringing it to the attention of our audience. You can still test autoantibodies, but you have to always put it in the context of what could be in the immunoglobulin. So some people could have asymptomatic autoantibody presence, even if they are healthy, and we can see a little bit of autoantibody presence in immunoglobulin products. However, when you have very, very high numbers of anti-thyroglobulin or anti-thyroperoxidase, many of these autoantibodies are much, much higher in a level, then we think that probably it's real and it is made by the patient and not coming from the immunoglobulin. But it has to be really assessed by the clinician in the context of the clinical disease, and with the knowledge that some immunoglobulin products do have some level of autoantibodies, but not very high. Thank you.
The next question we have is cyclosporin better or worse for T-cell suppression than those you listed for second-line intervention?
I see a role for cyclosporin in certain disorders. For example, we use cyclosporin sometimes with bad atopic dermatitis, and still it is highly used in immunodeficient settings when you have an uncontrolled T-cell expansion. However, cyclosporin has some kidney toxicity, and levels have to be monitored very closely. So my personal preference is not to use cyclosporin as much as some of these other medications that have a better safety profile. So yes, cyclosporin could be used in certain cases, but it is clearly not one of my top choices.
Our next question, what is the outcome for lack of B cells?
Well, if the B cells are eliminated with medications, then we can sometimes face that the patient will have a problem reconstituting or basically making new B cells. And especially CVID patients after B cell depletion therapy can often become more severely depleted from B cells and more severely immunodeficient. We see sometimes patients even resurfacing as immunodeficient after they get rituximab treatment, and if they don't reconstitute the B cells and have persistent hypogammaglobulinemia. So there are several papers now written by us and others where we try to look at these factors of who will have a problem with their B cells after rituximab or other B cell depleting therapies. And we think that there are certain risk factors that you can assess in a patient before the medication is used. And we hope that these assessments will help you to decide, or the physician, what is the viability of using this therapy.
Great. Our next question, I have been diagnosed with neutropenia along with my PI. Is neutropenia a cytopenia?
There are several reasons why you can have low neutrophil count. It is either the problem of low neutrophil production in the bone marrow, or the neutrophils are eliminated by certain autoreactive clones in the periphery. So the first question I would ask in your case, whether you have a bone marrow problem or is it a destruction in the periphery. If it is a destruction in the periphery, then it is autoimmune, and if it is a bone marrow problem, then it could be bone marrow failure. Most likely, if you have immunodeficiency, you probably have an autoimmune cytopenia, autoimmune neutropenia in the periphery. But you have to see it in the context of your underlying disease to make the final call of what is the reason for your neutropenia. You can look for antibodies to the neutrophils to decide whether it is an autoimmune process, but this test is not highly sensitive. So we do see patients with negative antibody tests until we think that they have autoimmune neutropenia. So it's a complicated process, but it's worth going behind the neutropenia and understand what is the driving force of this.
Our next question asks, can you explain ALPS or ALPS in PI patients?
Excellent question, and I'm so glad to hear all these questions coming from our community. ALPS is primarily followed by hematologists, but I think we have to have hematologists and immunologists work together to serve this patient population best. It is an abbreviation for autoimmune lymphoproliferation syndrome, and lymphocytes cannot die in time, so there is a lot of lymph node swelling and often cytopenias presenting in the patient population. Because these lymphocytes are circulating too long, they can become autoreactive, and the goal is to literally try to eliminate the autoreactive cells, in particular the T cells that are going to be autoreactive, and this is why sirolimus is such an effective medication. In this group, there's a major heterogeneity, like variability of this disease, even within the same family. And I have seen patients where the mom was completely asymptomatic, whereas her daughter had significant, like extremely large lymph nodes in the neck and had cytopenias. So you have to take it in the context of the clinical presentation, how aggressively you want to treat this disease. But it's definitely one of the most common disorders that we see. When you have it in the context of CVID or other immunodeficiencies, you have to think out of the box and think of a possibility of an ALPS-like disorder, which is not going to be ALPS, but ALPS-like. And then we are entering this whole new field of primary immune regulatory disorders, or PIRDs. But you would have some similar features, but also CVID or immunodeficiency phenotype. And those patients would need very different treatments, mainly regulatory T-cell therapies.
Great. Our next question asks, is autoimmune alopecia common or rare in PI patients?
I'm really excited to hear all of these questions. I do believe that alopecia is actually a feature of immune dysregulation in immunodeficient patients. Our team in particular is working on some of the SCID genes like REG deficiency, and we find a very high enrichment of alopecia and vitiligo in this population. And when I'm looking at the landscape of many immunodeficiencies, both vitiligo and alopecia is frequently seen in our population. So I truly believe that it is a feature of immune dysregulation in immunodeficiency, and there is very active research going on at University of Massachusetts with Dr. John Harris, and we actually are trying to join forces with him on this kind of research. So please stay tuned. Thank you.
Great, thank you so much. And now we did have a question. If an attendee was interested in receiving any of your contact information, is there any way to be able to receive that?
Yes, I have an email address available. It's basically my first name, last name at usf.edu. We are always available for questions through our clinical line, and then depending on how close the patients are, I would be also happy to see them if they live close to Florida. Yes, thank you.
Great. Well, that is all the questions that we have for today. So, and looks like we're nearing the end here as well. So, anyone, if you have any further questions, please don't hesitate to reach out to IDF. We're here to help. But it really looks like our time has come to an end. Again, a few minutes early here. Again, thank you so very much, Dr. Walter. It has been an honor to have you join us today. And everyone, please enjoy the final day of the conference. Thank you.
Thank you. Have a good day. Bye. Bye-bye.